Hello, everyone. Welcome to the Recovery Planning and Behavioral Health with the MHTTC webcast, and we'll start now.
Good afternoon, everyone. This is Janis Tondora, and I'm going to be one of your presenters today along with my colleague, Dan Wartenberg. Dan and I are going to do a bit more of introductions in a bit, but I wanted to start with some logistics and context of the MHTTC initiative for those of you that are not familiar. So just a bit about the mission. The MHTTC mission really involves using evidence-based means to disseminate evidence-based practices to promote the resilience and recovery of persons at risk for, living with, or recovering from mental health conditions and their loved ones. To achieve the same, MHTTC provides training, technical assistance, and resource and tool development for the mental health field within the New England region, which is designated as Region 1 within MHTTC. And throughout the structure and the activities of MHTTC, we're really striving to ensure that the work is informed by a diverse group of stakeholders that are invested in the mission, including but not limited to government officials, policymakers, systems leaders, administrators, different community stakeholders, providers, researchers, and really most importantly, youth and adults and family members who have lived experience of mental health conditions themselves. The focus area of the MHTTC is on recovery-oriented practices within the context of recovery-oriented systems of care. So we're beginning with person-centered recovery planning today, since it really is considered a fundamental practice in any recovery-oriented system of care. I just want to remind folks on the line that today is part of a two-part series of webinars, the second of which is going to happen on June 19th at the same time. I'll tell you a bit more about the two-part series and the organization of those in a bit. But also wanted to mention, we do have folks on the line today from all over the country. We had a great turnout for this webinar, which is fantastic given the importance of person-centered thinking and practice. But in addition to this webinar series, I also wanted to let folks know that later this fall, organizations that are within the New England regional MHTTC area will actually have the opportunity to apply to become part of a longer-term interactive learning collaborative, which will actually provide ongoing training and technical assistance to its members. So that's an opportunity that we are very excited about, and we hope that some of you on the line will be excited as well and choose to join us. So let me just cover a couple of last-minute housekeeping items. Just a reminder that if you're calling in on the phone line, to please mute your speakers, your computer speakers. That'll help you avoid any kind of echo on your end. And if you have technical difficulties with that, please use the chat box on the bottom left. Someone will try to assist you with that. Also want to make sure that you're aware that this event is being recorded, and the recording link will be posted on the MHTTC website. Hopefully by Friday, for people to review the chat and rewatch the presentation. And then in terms of our management of questions on today's webinar, I just again want to direct your attention to the chat box for participants at the bottom left of your screen. And Dan and I would really want to encourage you to use that throughout the webinar to post not only questions but also comments and ideas. Dan and I are going to do our best to keep an eye on that chat for each other while each other are presenting. And we may actually choose to pause in our remarks to address a question on the spot, but we're also going to plan to each try to speak for about 30 minutes or so we leave some time at the end for additional Q&A. And if by chance we do not get to respond to all of the questions that are posted, or if you have questions that bubble up after the fact, please send them to the address posted on the screen here in the MHTTC. We'll forward those to Dan and I, and we'll be sure to revisit them on the 19th together. In terms of CEUs, we are offering CEUs for this webinar series to those who attend both sessions of the webinars. So please note that you do need to attend both in order to be eligible for the certificate. And then following our second webinar on the 19th, you'll also need to complete a brief evaluation and knowledge check about the content, which you'll access through a link that will get sent to you via email. And after completing those, you'll be able to request the CEUs. And if you need to contact MHTPC about any of these logistics, here we're just providing you both with the link to the MHTPC website, as well as an email address that you can direct your questions to. So a quick plug before we move on to the content of today's webinar. I just wanted to call your attention to the wide range of webinars and educational offerings that the MHTPC will be hosting throughout the rest of the summer. So we hope that many of you will visit the website, register, and choose to join us for some of these future events. So I think that covers it for our logistics and housekeeping. So Ingrid, if you could go ahead and pull up our content-based presentation, that would be great. I think we're ready to move ahead. And actually, while we're doing that, before we go on to the content, Dan and I wanted to just tell you a little bit about our background and the experiences that we kind of bring to the table today that we hope to share with you. Since I'm going to be covering much of the content in the first half and Dan will be covering in the second half, I do want Dan to have an opportunity right now to kind of jump in and just say hello and tell you a little bit about himself. So Dan, if you can unmute and jump in for us, that would be great.
Hi, everyone. My name is Dan Wartenberg. Thank you very much for joining us this afternoon. I've been in this field for probably about 40 years now and have been on what I would call the sort of the implementation journey of person-centered recovery planning for probably about 15 years of that. By training, I'm a psychologist. I'm still an active clinician. I have served as a QI director, run inpatient units, outpatient units, been the CEO in a state-operated mental health authority, and I'm currently the clinical director at a community mental health center in Rhode Island. I became impassioned about person-centered care, actually hearing a presentation that Janis did about 15 years ago. And like I said, when I sort of get to my section a little later on, I'll tell you more about my journey and how the whole implementation path has evolved over that course of time. So anyway, thank you again for joining us, and I'm glad to be here.
Great, thanks, Dan. So I'll jump back in here and just say hello and tell you a little bit about myself. So I am Janis Tondora. I'm an associate professor at a place called the Yale Program for Recovery and Community Health, which is a Department of Psychiatry program at the Yale School of Medicine, but that works in close partnership with our public sector behavioral health system here, the Connecticut Department of Mental Health and Addiction Services, that has been a big supporter and champion of this kind of work for many years. I'm a clinical psychologist by training, but the way that I actually came to this work in particular, I have a family member who experienced a traumatic brain injury going back about 25 years or so ago now. And in the process of being beside him and his recovery and his different planning processes, I really came to carry and value the power of person-centered thinking and practice, to sort of carry that in my heart. And then as I transitioned in my career and went back to grad school and I started doing behavioral health work, and I was working as a practitioner, an administrator, a researcher, a policymaker, many different hats in my travels. But through those travels, despite carrying a lot of these values in my heart, I often struggled to really translate the philosophical values and concepts into concrete practices that could really improve the quality of care in routine service settings. And a second area that I struggled with was really learning to sort of identify and then manage really a wide range of implementation obstacles that oftentimes felt like they were beyond me and beyond my locus of control, if you will. So this has been a developmental learning process for me over time. I don't think that I'm alone in those struggles. I think there's many, many folks out in the field in different roles that this method of partnering with people and doing planning, it fits with our values and what's in our hearts. But the lack of sort of concrete practice guidelines and also attention to systemic issues can often get in our way. So Dan and I have been very intentional in the design of this webinar series to really try to address some of those struggles. So let me give you a big picture view of what we hope to cover across the two events. So today we're really going to be starting a bit with more of a bigger picture overview to set the stage for increasingly more in-depth and applied information on tips and tools and resources, et cetera. I'm going to be starting with some introductory comments and background. I'm going to introduce a model of how to sort of think about the component parts of person-centered recovery planning. And I promise you that I will be at least dipping our toe into the documentation of person-centered recovery planning today, because we know that's a big source of confusion and frustration out in the field. And then I'm going to turn it over to Dan, who, as you mentioned, he's a very experienced leader in implementation efforts on this topic, both in the state of Connecticut and also in the state of Rhode Island, right now where he's currently based. So Dan is going to actually share a bit more of kind of lessons learned in implementation. And I'm sure Dan will agree when I say that sometimes those lessons that we have learned along the way in the last 20 or 30 years, sometimes they're learned really the hard way. So this opportunity on the webinar today is a chance for you all to benefit from kind of what we've learned along the way, and hopefully to be proactive in addressing some of the ways in which our implementation efforts can be hindered. So next time on the 19th, again, this is a two-part series. We're going to take a much deeper dive into the documentation, talking about everything from the documentation of assessment to integrated summaries to the core documentation components of the plan, really with an eye toward helping people to see how, in fact, it really is possible and, in fact, preferred. We can write a plan that both honors the person and it still satisfies the chart, you know, a plan that can simultaneously respect professional expertise as well as that wisdom of lived experience. But sometimes, even when we feel like we have the skills and competencies to partner with people and write plans in that way, to co-create them in that way, we sometimes are then trying to document that plan in the context of a treatment planning template or increasingly electronic health record platforms. And Dan and I wanted to work a piece into the webinar on the design of EHRs, both really the promise and the pitfalls of them insofar as they can support or undermine person-centered practice, because that's an intensive area of work that I've increasingly been doing around the country, including an interesting initiative that I've been working on with Dan. So that gives you a bit of a preview of what we'll be covering on the 19th. And a bit more detail here, just to give you a sense sort of how we've learned, what we've learned, and the experience we're bringing to you all today. As you can see here, our comments really are informed by a mix of both rigorous research projects and randomized trials, and also extensive training and technical assistance efforts, where we've really worked hard to translate that research in the field by partnering with stakeholders across many, many states in the U.S. And even internationally. And then throughout that, we've really tried to be mindful to collaborate with key sort of national accreditation, fiscal bodies, funders, et cetera, to make sure that there's an alignment in the quality message around person-centered care and planning. And Dan and I have both had experience working with CMS and going through Joint Commission reviews, CARF accreditation, et cetera. So we do try to be mindful of that and are going to share some tips and strategies as we go. So let me just start with a bit of a silly image here, but I actually think it portrays a pretty significant issue. This cartoon really makes me think of the endless road trips I've taken with my own antsy kids through the years, kind of constantly asking, are we there yet? Are we there yet? And one of the dilemmas whenever you're on a long journey or in a process of transformative change is it really need to know where we're going on the journey, and we really need to make sure that we can recognize the destination when we get there. And there's actually a tremendous amount of confusion in the field around what person-centered recovery planning looks like, both in process and in documentation. So it's important for us, we really want to talk a little bit about both of those aspects, both what it is and frankly what it is not, because there's a lot of myths and misperceptions that are out there in the field. So let me just give you a sense of some of the forces that are behind person-centered recovery planning for those of you that may not be as familiar with the context behind this kind of work. And just a technical point for the audience out there. At the end of our second webinar, we'll be sure to put together a couple of pages of key resources, including citations, websites, et cetera, for those of you that would be more inclined to kind of go get more in-depth information about some of these things and the forces behind recovery planning that kind of drive this agenda. So first and foremost, I really just want to start with a simple thing, which I often refer to as the golden rule, that this is a values-based approach. And I always ask people when they seek my consultation on how to handle something, I always say to them, think about a person's experience the very first time they walk through the door of your behavioral health center. Think about the partnerships that we make in planning and the conversations that we have with people. Think about a person's experience when they actually get a copy of their plan and they read it. And if you're struggling around how to organize and design those things, just ask yourself, if it was you, or if it was a loved one, if it was a parent, if it was a child, if it was a close friend, and they were having that experience, how would you want them to be treated? How would you want yourself to be treated? Because there's really no stronger guide than that in doing this work. So I do like to start there. And in recognition of the values base of this, person-centered thinking and practice, I really call it the perfect storm of forces out there driving this, which includes everything from endorsement by state behavioral health authorities. Dan will probably tell you a little bit about his experience in Connecticut and Rhode Island around that. Certainly at the federal level, there's endorsement in everything from the Freedom Commission report from years ago to SAMHSA. There's a very exciting new National Center for the Advancement of Person-Centered Practices and Systems that's emerging. Funders, interestingly enough, and accrediting bodies, it used to be the case that oftentimes people would say, well, I would go about my planning in partnership and I would document it in this way, but I can't because my funder doesn't allow it. And while we understand that there's still some confusion in the field around that, I really want to take this opportunity to point out that some of the major funders, including CMS, for example, they not only increasingly have supported person-centered approaches to recovery planning, they in fact now require it and have built it into regulations and requirements in the 2014 CMS rule, et cetera. For those of you that are more data folks, we've got a lot of evidence and data emerging out there that shows that we get improved outcomes around traditional clinical outcomes, as well as around very valuable recovery outcomes, such as sense of belonging in the community and homes in the community and meaningful activities and relationships and jobs, et cetera. And there's even some interesting emerging data that comes out of more of an economic angle to the research that shows that when we work in a person-centered way with people, that in fact we can realize some fiscal savings. And in part, that seems to be because when we're working in a proactive, person-centered manner, do planning with folks, while that takes some investment of time on the front end, it really does seem to result in higher quality plans that people are more invested in, that can have significant impact on things like hospitalization rates and ER usage, et cetera. And I'm sure all of you on the line are aware that those are really our most cost-intensive services in the system. So we even have some evidence to show this is not only recovery savvy, it's also fiscally savvy. And then finally, what I'd like to say, the most important voice driving this push around maximizing our person-centered orientation to planning, it does come from the voice of service recipients. And I've included a couple of quotes up here that I think are important and reflective of that perspective. My favorite of all time is the one on the bottom there. I was sitting with a consumer advisory council years ago here in the state of Connecticut, and I was all jazzed up and excited about person-centered approaches to planning, and a woman really kind of stopped me in my tracks and said, well, wait a minute, you know, you keep talking about getting me in the driver's seat when half the time I'm not even in the damn car, right, is what she said to me. And we kind of chuckled at the time about it, but she went on to tell a pretty sobering story, which was that her experience in planning, she'd go to the mental health center, a whole team of people would meet behind closed doors, they'd have a discussion about her life, about her recovery, and then after about 20 minutes or so, they'd kind of open up the door and they would invite her in to be a part of that conversation. And if we're being honest with ourselves, the most important decisions about that woman's life and her recovery really had already been made without her. So she wasn't feeling like she was in the driver's seat. She felt like she was in the back seat, the trunk getting left on the curb, and so forth. So that is not to discount the fact that we've made a lot of progress in recent years, but it's important to recognize that we still have a ways to go. And the next thing we'd like to do, we're going to ask for your help here, try to make this a little interactive. Dan and I would like to get a sense of the different implementation concerns or barriers that might be getting in your way when it relates to implementing this practice. So what you see up on the screen are just 7 different common implementation barriers that have been pointed out to us. And at the bottom, you should all have the opportunity to select one of the bubbles on the far left. So if you can all take a read through those now, I'm going to give you a couple of minutes. And then this feedback from this poll will kind of help Dan and I to get a sense of where you're at so that we can try to tailor the comments and what we emphasize over the course of the 2 webinars. So please go ahead and do that now, and we'll give it a minute or so, and then we'll pull up the results. Just a few more seconds, if you don't mind. As I'm looking at these, we're not going to go in depth into these right now because Dan and I are going to come back to them throughout the presentation, but it is looking to me like a couple of the big areas that either folks on the line are feeling or colleagues or people in your organization. So some sort of confusion and questions around, well, you know, don't we already do it? And is it really any different in practice? As well as some questions around, you know, how do you really work this way with someone who may have significant impairments, maybe in their communication, their ability to partner with you. So we're going to come back to those and come back to the results of the poll. But in the interest of time, I'm going to move on here. And let me start with this one, because I do think this is perhaps one of the most common things that we hear in the field, this question that, you know, we go into the field to help people, we try to put their needs and preferences first, you know, don't we already do it? And I would argue, based on my travels, there's a tremendous amount of wonderful person-centered work happening in the field. But when we really start to look at the details and talk to people about their experience in care, when we kind of take stock of different concrete planning practices, and when we look at actual written recovery plans themselves, we still have a ways to go. So we're going to cover some of that territory in the time that we have left in the webinars. Please do not worry about the tiny screenshot of the instrument that's on the screen here. That is one of the earlier tools that we developed. It was one of our earliest efforts at the Yale Perch program in partnership with Connecticut Demas to develop a tool that really said, if you're doing person-centered recovery planning, what does it concretely look like in practice? If you're having a planning meeting, a conversation, also if you're actually co-creating a written recovery plan. So I'm going to share some of that content with you now, and for those folks who are interested, you'll see at the bottom of the page, I've actually inserted some web-based links where you can actually go and get copies of these instruments. And one thing that we've done, just so that you're aware, we have these instruments so that they're written with the same items, but there's a version for practitioners, a version for administrators, but very importantly, also a version for people receiving services, so that they too have an opportunity to tell us what we think is working well and where we maybe need to make some improvements. So one of the reasons there's confusion about person-centered recovery planning is that sometimes it can feel a bit like a fuzzy concept. This is just a quote from an article that we wrote years ago. And one of the issues is that people really struggle to understand exactly what it is and what it might look like in practice. So this person-centered recovery planning, it really is an opportunity to move past the theory, past the values, recovery-oriented care, to really do some things differently in the field. But it's hard to hold people accountable to deliver something that you haven't operationalized in practice. So let me tell you a little bit about what we think that looks like and give you some ideas. So what you're looking at up here, this is a screenshot of what we call the 4 Ps model of person-centered recovery planning. And what we talk about is the base of the model. We talk about the philosophy of recovery, really believing that folks can and do recover and that they can and should have control and meaningful input over decisions that impact their life and their recovery. Those values inform a different way of partnering with people, a different kind of a process in carrying out meetings, whether they're team meetings or whether they're one-on-one meetings. From that type of a process, we hopefully are creating an enhanced type of a plan, whether that plan is co-created in writing or in the context of an electronic health record, and all along the way recognizing that we're working together in this way with people for a different kind of a purpose, right? So for more lofty aspirational life outcomes that go beyond clinical stability, to really talk about the importance of a valued life in the community, however a person defines it. There's another website embedded in the green text box at the top of there, the pyramid, and I just wanted to call your attention to that. This graphic is linked to an interesting global mental health initiative that we did in partnership with some folks across the pond, where we not only created a series of tip sheets around each of the 4 Ps, we also produced a pretty interesting 7.5-minute video that introduces people to the topic, and they did a beautiful job with it, and a lot of folks have given us feedback that it's been useful in staff meetings and new employee orientation, et cetera. So I just wanted to call your attention to that as a potential resource. So let me just tell you a couple of, this is not an exhaustive list, but to highlight a couple of the key practice guidelines that we encourage people to think about at the process level. So obviously we want folks to be a partner in all planning activities and meetings, making sure that we give them advance notice wherever possible. We've got programs around the country doing really creative things where they're using electronic health record trackers to be able to send automatic reminders for people. And that's all really intended with the idea that if we truly want people to partner with us, we have to get past one of our senior peer specialist supervisors, Kimberly Guy, often talks about really the power of the pop-up meeting and how that can put a person in a position where they're not prepared to participate and partner with you. So you may get a cancellation, if you will, and someone may be at the center, and you may have had an alarm go off that morning when you turned on your computer that their plan was overdue, and so you kind of grab them and you say, listen, I've got 15 minutes, and what are your hopes, dreams, and desires, ready, set, go. And just recognizing that, while we have those tensions certainly around our timelines and whatnot, that person's not going to be adequately prepared to have a meaningful voice. So something as simple as advance notice, making sure that folks have input, reasonable input over the logistics, So who's involved, when and where that meeting takes place, who facilitates the conversation in a way that really honors the person's preferences. Please note that I said reasonable control over the logistics. That doesn't mean that we're saying that people should be able to call you up and say, I can only come in at 1 o'clock on the third Tuesday because that's when my mom can come with me. That would go beyond what we would think is reasonable, but again, go back to your own personal experiences and the golden rule. I know that I myself have some serious health issues, and my husband is a huge part of my medical decision making, so I call my physicians up and I often say to them, we'll come in any day of the week, but I really need an appointment after 3 p.m. because it's important for me to have my husband there with me around making some of these decisions. And 90% of the time, if not more, that's honored. So that's what we're talking about. Are we really doing that consistently in the context of behavioral health? The critical nature of operating from a place of transparency and making sure that people are getting written copies of their plans, that they not only get a copy, they have an opportunity to go over it with you, to offer you any feedback. We really see the plan as a manifestation of the partnership and ask people to really consider, if we're not automatically offering a copy, what kind of message does that send to the person about the partnership and about the value and the role that they played in the process. There's also some implications just for sort of a shift in the structure and the roles that people play in planning meetings, just to maximize the input and the preparation so that people can find their voice in advocating for themselves, articulating what's important to them. And lastly, not underestimating the fact that some individuals are their own best advocates without any additional support, and we just need to make space for their voice. But for other people, if you use the analogy of a driver's seat, if they've been used to being passive in the process and they've felt more like passengers, if you will, they might need a little driver's education about what it looks like for them to really be a true and active partner. So to that end, I just wanted to tell you one example of a tool of a project that we've been working on that really recognizes the importance of educating people in recovery. This is a snapshot of a multi-year National Institute of Health Small Business Innovation research grant that our program at Yale has been doing in collaboration with C4 Innovations, previously known as the Center for Social Innovation. And what we've been doing, we've developed really these innovative multimedia tools and online curriculum platforms to really increase the uptake of recovery planning and behavioral health settings. And they make the very best use of cutting-edge technology around embedded video and lots of interactivity, experiential exercises, opportunity to relate the content to one's own experience. But really critically and intentional by design, we have an online training platform both for practitioners but also for service recipients. Again, going back to this idea that if true person-centered planning is about partnership, we cannot only educate and build competency in one half of that partnership equation. We need to recognize that people who receive services also might need some additional tools and skills and confidence, et cetera. So we are very excited that that tool has been developed. We're in the middle of a randomized trial where we're testing it right here in some community support programs in the state of Connecticut. And of course, the MHPPC, we really hope to keep you all posted on the progress and to let you know as additional materials like this are available. So a few more key practices, just recognizing that the range of contributors to the planning process might shift over time. Obviously, we talk about the importance of not just including core clinical or rehabilitative staff members, but really talking to the person around who is in their circle. Is it a family member? Is it a friend? However they define family. It could be a representative from a faith community. It could be a neighbor, et cetera. And wherever possible, we talk about capitalizing on the role of peers, peer specialists. We could do an entire presentation on this. Maybe I'll have an opportunity in the future. But when we talk about making sure that you educate both sides of the partnership equation, anyone who's committed to the values the practices of person-centered planning can support people who use services to become more active in this. With the places that have gotten really the most leverage and meaningful implementation are the places that have capitalized on the talents of their peer specialists to do some of that education, to do group-led educational groups on recovery planning, to have office hours where people can sign up and come in advance of their plan to help them organize their thoughts and whatnot. We also talk a lot from a key practice perspective about recognizing that much of this is about understanding and supporting a person's right to self-determination. People really, should have meaningful input and control over these decisions and the kinds of things that really end up as the core content on their plans. That could also include the use of things such as wellness recovery action plans, right? So if we know that people, in the process of working on their recovery, they've learned what works well for them in terms of daily tools and strategies, we want to start with that and honor that as a way of informing that comprehensive recovery plan. Same could be said of the use of psychiatric advanced directives. Really nice example of a recovery-oriented risk management tool that helps us really support somebody's dignity and autonomy even during times of crisis. In more subtle ways, we talk about the importance of not undermining folks' efforts toward recovery when we talk about their efforts to connect to community life and activities, and I'll give you an example of that in a second, as well as an example of how strengths-based approaches might play out in planning and documentation. So let me just say a word about this in terms of how person-centered recovery planning thinks about community inclusion. And a person's really their right to community inclusion. Historically in treatment systems, we tended to think of this in a linear way, where a person was struggling with some kind of experience or symptoms, and they entered into this box called treatment, if you will, and that really the task was to ensure that someone is, quote, clinically stable, and then once we've kind of wrapped them up in a neat little bow, then they sort of go forth and they experience jobs and faith and community, et cetera. So it was much more of a linear model where people were expected in some ways to demonstrate clinical stability before we supported them in things like, getting into employment programs, moving on from residential settings. So just to give you a concrete example of that, we've made a ton of progress in the area of supported employment, and I want to make note of that. But I do still hear in my consultation around recovery planning where someone has made it very, very clear that their driving goal in their recovery is that they want to get their job back so they can be a good provider for their kids. But unfortunately, what will often happen is that people will get the message, when you've been clinically stable for 3 months and you've been out of the hospital for 3 months, or when you've been abstinent or you've done 90 meetings in 90 days, then your clinician will refer you to the job program. So that's a very concrete example where we are really sort of putting off people's pursuit of things like jobs and community activities, when really things like having a meaningful job, having somebody to love, a place to live in the community, they're not the reward at the end of the recovery journey. They're the reason that people take the first step. So that's why we talk about this really as putting the person at the middle of the model and simultaneously helping them work on things that might be getting in their way while not delaying the pursuit of those goals that are most motivating to them. What you have up here, I'm not going to go through this just in the interest of time because I want to make sure that I end, as I promised, with a quick documentation preview. This will be in your slides when you get them, but on the top, just to orient you, we've got a snapshot from a note that was written from a pretty traditional deficit-based perspective, and then we really reworked that same content, thinking through a person-centered, recovery-oriented lens. I can't underestimate, really the power of language is critical in all of this. Depending on the words that we use, if we use deficit-oriented, terms that kind of communicate the stories of people's lives, we're going to have a very hard time backing our way out of that into a good, positive, strength-based plan. So we're going to come back to these common concerns a bit later when Dan talks about some of the implementation. A couple of them, quickly to touch on, and we'll give you strategies in a bit. If the person's in the driver's seat, where does that leave me? People often say, like, does this devalue the role of the professional or clinical treatment? And I want to send a very clear message that that is not the case. This is a model based on partnership. You're right there in the car beside them. You may also have a family member. You may have a neighbor. So this is a method of planning, both in process and documentation, that makes space both for the wisdom of lived experience and the valuable professional expertise you bring to the table. And it also, partnering does not mean that you always have to reach agreement. There's going to be times that you see things in different ways based on occupying different positions in the process. So sometimes you're going to have to agree to disagree, but we talk a lot about the importance of making sure that we do that in a way that is based in mutual respect and an understanding of the person's unique perspective. And finally, before I preview the plan for you, no one is ever too sick to engage in person-centered recovery planning, okay? We really see this as a fundamental right of all individuals in a quality system of care, but, and this is a big but, having said that, we also recognize that how it plays out in practice may look very different, right? So people who are in high-intensity, inpatient, mandated forensic hospital settings, the approach is going to need to look different from a practice perspective to someone who's living and working in the community. They're in a lower level of care, perhaps in one of your rehabilitation programs. And so you may not be able to demonstrate all practices of all people, but recognizing that whatever practices we can implement, we have a responsibility to really try to do that. So last thing before I turn it over to Dan, the documentation challenge. Oftentimes we know that there's beautiful person-centered work happening in the field, but unfortunately, oftentimes it doesn't make its way into the documentation. So I encourage practitioners to think about this kind of training and consultation as an opportunity to sometimes really get credit and get recognition for the good stuff that's happening that's not reflected in the documentation. Part of the reason that it's not, as you see up here, it's like fitting a square peg in a round hole, and we've got this complex mix of regulatory and fiscal requirements. So ending with the example here, and again, we're going to do a much deeper dive with this next week, really focusing it on the plan and the documentation. This is a story of someone, we'll call him Mr. Gonzalez. He was a young married Puerto Rican man. He was living with bipolar disorder, and he would use alcohol to manage distressing symptoms. And he had gone through a period of acute mania, and he was having big arguments at home with a wife in the presence of his two little boys. On one occasion, he actually put his hands on his wife, and he had shoved her to the floor, which prompted a call to the local police. And then when the police arrived at the house, he was uncooperative. He was pretty upset. He got admitted to an inpatient facility for evaluation. He came out to the outpatient mental health center, and his wife was open to reconciliation. She was actively involved in his treatment. And he talked about his love for his family and his faith in God are what kept him going in difficult times. So long story short, I got a phone call from the team supporting Mr. Gonzalez. What they said to us was, we think this gentleman has a lot of potential, but he's refusing to participate in any of our services. He won't agree to meet with a psychiatrist. He's not showing up. He's pretty angry with us. I said, well, okay, send me the plan, the working plan you have for Mr. Gonzalez that's shaping this interaction. And so essentially, this is the plan that was sent to me. Goal number 1, achieve clinical stability. Goal number 2, reduce your assaultive behavior. Goal number 3, comply with your meds. Okay? So my feedback to the team was that it was actually not surprising to me that he had disengaged and that he was not partnering with them in the process of moving forward. Because he was feeling like this, I'm here to return your goals because you left them on my recovery plan. Because his goals in life are not to take his lithium and increase his insight, reduce his assaults, et cetera. Really, this is the kind of stuff that spoke to him. And these are the elements that we'll go through, tips and documentation strategies for each element on the 19th webinar. We went down, we met with Mr. Gonzalez together, we invited him into the room. It was one of the most powerful teaching moments, learning moments, as a person in my own career. He was a very proud father, and he came in and he broke down in tears and just said, I want to get my family back. I don't ever want my boys to be afraid of me again. He had a range of strengths to draw upon. He was a very devoted dad, high motivation. His wife was still involved. His Catholic faith and prayer were a big source of comfort for him. And he did have a positive connection to the peer specialist. At the same time, he had acute symptoms, which led to violence in the home, kind of a lack of coping strategies to manage the stress. And then in the absence of that, he would tend to drink alcohol, which only further escalated some of the difficulties that he was having. So hopefully what you're starting to see here in this example is that there really is a balance. We're not disregarding. He does have significant issues from a mental health and addictions perspective that are interfering with his life, and they need attention, but not to the exclusion, and making sure that they get connected back to what's most important to him in his life. So just one sample quick objective that we came up with. The team and Mr. Gonzalez all agreed that he was going to apply some different kinds of coping strategies to have positive interactions with his wife and kids during one supervised visit and family therapy session within that 30 days. And there's an asterisk by positive because we would have, I can only fit so much on the slide, but it would have been sort of defined with Mr. Gonzalez and with Mrs. Gonzalez. What does that look like? Is it a certain tone of voice? Not having any unwanted physical contact, certainly no posturing or aggression. And in that objective, Mr. Gonzalez saw that this team was committed to him to help him see his wife and boys within the next 30 days. And in order to help him be successful in doing that, what you see at the bottom there's a range of different services, some being more clinically or rehabilitative oriented, delivered by professionals, so some medication management to reduce his irritability and those distressing symptoms, maybe some family psychoeducation and family therapy. We had a rehab specialist doing some coping and communication skills training. And then finally, one of the key distinctions in PCRP documentation is we don't limit the interventions to those that are delivered by paid professionals. We also think about what can you tap within the person's sort of strengths inventory, within their circle, within their community. So we tried to use Mr. Gonzalez's, his deep sense of faith and spirituality, and to pull in some spiritual counseling from the agency chaplain that could easily have been from a priest in the local community, to really help him draw upon that strength as a way to manage the stress, along with the Wellness Recovery Action Plan that he was going to develop with that peer specialist. And each of these interventions hits those key documentation components of who's doing it, what are they doing, on what schedule, and for what reason. But I would argue that, that is an example of a plan that shows you that it is possible to honor both the person and satisfy the chart, because that's a sample of a plan where you're both respecting what's important to Mr. Gonzalez while at the same time not neglecting important things from a professional perspective that you think might need attention within his plan. So I went a couple of minutes over after also covering our introduction, but I'm actually going to go ahead and I'm going to turn it over to Dan to make sure that he has time for his section on implementation, and then we'll leave time at the end to come back for questions.
Thanks, Jana.
Sure.
So I'm going to talk about sort of what I've learned in the last 15 years or so about how to implement this. When I've heard Janis speak many times, and I'm sitting here thinking, well, why wouldn't everybody want to do this? This is great. This is, it's a sound clinical approach. It will satisfy requirements. But when you get out there, everybody isn't doing it, or at least not yet. So I think there's reasons for that, and in a way, it's almost a parallel to the person-centered plan that, we have a goal of having plans and practices that honor, respect the person, empower them But along the way, there are a bunch of barriers that need to be overcome. So I'd like to kind of talk about those, the ones I've experienced along the way and how we dealt with them in different settings, and hopefully, some pointers that might be helpful to you all in going forward. I do want to say, like I said, I started this about 15 years ago, and there are so many more tools, resources, better definition now than there was then. When we started this, I remember it well. In Connecticut, there was actually a mandate from the commissioner saying this is the approach this state, is going to be taking, and we're going to put some money behind it. We're going to support it. And we were actually, in my facility, awarded a Center of Excellence for Person-Centered Planning, which was great. And we formed a committee, and we sat down, and we said, okay, we're excellent, and now what do we do? So things have evolved, and evolved significantly. Okay. So I've found sort of 4 major components, all of which are necessary to really bring about a successful implementation. Number 1, there needs to be strong commitment from the leadership. The idea that we talked about on the pyramid about philosophy, if that's not there, if there's not the will and the focus to stay the course, there are too many distractions along the way, and you'll get sidetracked. You need a competent, motivated workforce. So we're going to talk more about what that skill set might look like and how you also go about motivating folks to embrace this approach. There's, on top of that, you need an infrastructure that's actually going to support the implementation and not detract from it. So we'll talk some today and much more next week about what your forms look like, what your electronic health record looks like, what your processes look like, and do they actually support implementing this process, or do they get in the way? And the 4th thing is sort of an activated, empowered clientele who come to expect that their views will be driving the planning and the service delivery. Again, I think we've evolved immensely over the last 15 years, but still have a ways to go. I think when I started with this, people were not expecting that their views should be important in driving what was going on. So there was a significant education process going on. So I think since then we've done a lot in that area, but still ways to go. So leadership. So this, as you're probably gathering and listening, is not a simple process. It's a cultural change, and it's a different way of doing business. And one of the things you're going to hear me talk about repeatedly is you have to weave what you're doing into the entire fabric of your agency. So to offer a training, a one-shot training, isn't going to get it done. It takes place over time. It takes effort. It takes focus. And that has to come down sort of unequivocally from the leadership. Just a couple of examples. These are actually policy statements. One that was put out in Connecticut, another in New York, that, as I said, when we started this in Connecticut, it was clear from the top this was the direction we were going in. We didn't know exactly how to get there yet, but we knew we had to figure out a way because this was the direction of the department. So if you look, I'll take Connecticut, it builds the key concepts of person-centered planning, recovery planning into the actual mission statement. So I would encourage you all to look at your mission statements. What does it say? Does it reflect on recovery values? Does it reflect on empowerment? And does it include some of these key concepts, which become really the guideposts for people as they move forward? Okay, so once you have the direction, people are going to need help on how do you go about getting there. Again, part of what we're trying to achieve today is to offer you some guideposts in that and offer some resources in that, but there's a planning process that needs to take place that so you can thoughtfully put the pieces into place in some sort of meaningful way, in a way that people can actually absorb, that's going to create the change that you want. Okay? And again, that takes leadership sort of managing that process from the beginning. Again, I'm going to talk about tools and infrastructure that actually support the change. Again, the power of a form. You know, when somebody sees something on a form, a box on a form, they ask the question to get that box filled out. So it can drive a lot of things. And the whole idea of how do you build acceptance and buy-in as you go and as you affect this change. Okay, so one of the greatest challenges to this is keeping the focus. You know, people will often refer to the flavor of the month, and if they are not buying in, will wait for it to go away. All of you, I'm sure, are not dealing with one single implementation. I've kind of likened it to the process of trying to change a tire when you're going 60 miles an hour. Your business does not stop to do this implementation. So it takes place in the context of people doing the work, continuing the work, and having to shift gears while that's happening. I know, you know, wherever I've been, we tend to be implementing multiple things at the same time. So we may be working on bringing out new evidence-based practices. We're all looking for ways to find efficiencies and increase productivity. There may be initiatives on things like reducing restraint and seclusion. All these things, it's my experience, tend to happen at the same time. So how do you keep person-centered planning or recovery planning sort of at the forefront as you're moving forward? What I found that works is I find a person-centered approach, a recovery approach, is sort of an underlying glue that actually ties many of the approaches we're doing together. So, for example, when I was on inpatient and we were working on reduction of restraint and seclusion, so much that work became about empowerment, not getting into confrontations and power struggles with the people, which, if you think about it, is very simple, very similar to a person-centered approach, where you're looking to partner, find a common ground, honor what they want and think is important. And, you know, guess what? You do those things, those confrontations tend to go down. So in our implementations, we tended to place this as a central core principle that tied other implementations together and reminded people of that as we went forward. Okay, so your leadership is setting the tone. It's clear that we want to do this, and now you need a workforce that is both competent and motivated to move this practice forward. So my first point is this is really complex stuff. If you think about all the different skills that are required, and I kind of, I go back to, the slide Janis had about the concerns about, what about the clinician and what about my clinical skills? Does this sort of decrease the need for me as, the expert in a way? And I would contend, and it's been my experience, it actually takes a more sophisticated set of skills to do person-centered planning than to do non-person-centered planning. If you think about it, if the process, if the problem-driven process was more like, okay, here's my assessment of, what the problem is with you and my recommendations about what you need to do, it's a very different process than let's sit down together and figure out what's important, okay? So again, if you look at the different things you have to do, number one, they have to understand these concepts. So, we're just introducing it. There are a number of the idea of what person-centered planning is, what a person-centered approach is. It takes some describing. And as Janis said, people think of it as a fuzzy thing. It's not, but it takes some doing for people to actually understand that. And then there's a process of actually embracing that and seeing it as something of value and that they want to use in their practice. The process of engaging people and actually eliciting goals, preferences, so you need engagement skills. Again, it's a very different process than just telling somebody what to do. You need to be able to formulate and integrate complex information from different assessment sources to understand the person and understand the nuances of what's important to them in the context of what you understand to be going on clinically. There's this, when Janis mentioned the process of coming to a joint understanding, actually a negotiation process. Think about it. Somebody comes in, they may be actively using substances, they may not be an immediate risk, but you're clearly seeing this as a problem in their life, and they may not think so, okay? But you want to come together to work on a plan that's mutually agreed upon. And that's going to take some clinical work to do. People would say to me, well, I need to put it on the plan anyway. And the people in recovery would say to me, well, fine, you put it on the plan, that's nice, but I'm not going to do this. I don't really think it's a problem. So there's a process of being able to talk with a person and come to an agreement on how you see things, or at least an agreement to disagree and how to move on together. People need to know how to write. I don't know how many times you can talk to someone or talk to a clinician and you know that they're getting it, but they just don't know how to put it into writing. We tend to skip over that, but it's really a core competency to be able to do this work. And finally, now in this day and age, and we'll talk about this much more, you need the technical skills to be able to negotiate an electronic health record, hopefully one that is easier to negotiate, but you need to be able to do that. There's a few tools here. Again, you can't see this very clearly. That Janis, if you want to jump in a little. So I just show these as an example of actually how you can break those competencies down a bit, because they're actually very good tools that show you the components. One of the things that, again, that I've learned in an implementation, if you look, I'm presenting this as this big thing that typically could be very overwhelming to people. I got to train my staff. I got to, have a culture change. We're going to talk about other factors. Again, it's almost like a recovery plan, that there are components that you can break down, train, measure, reinforce. Okay.
Yep.
So,
and Dan, if you want me to step in, I'll give a little bit of the context for the group. So what you're looking at here, I want to give a shout out to any of my friends and colleagues from the state of Texas who happen to be on the line, because this is just a quick screen capture of a sort of statewide quality audit tool that was used within the behavioral health component by the Health and Human Services Commission, previously the Department of State Health Services in Texas, where they did something that I think was incredibly innovative and very impactful, which is that we had a multi-year, and still have a multi-year, person-centered recovery planning implementation effort in the state of Texas. And sometimes states, they kind of think of those as like separate add-on special projects, and if you want to measure the outcomes of it, you have sort of a separate set of outcomes over here. But like Dan keeps saying, the important thing, if you want to make this stick from an implementation perspective, is that you need to build it into the fabric of the work in the system. So this is an example of a quality monitoring tool. Instead of having something totally separate for that special person-centered planning stuff, we worked through a course of, I think, 17 different versions with representatives from the QM department in the state of Texas, and collaborated so that the ongoing audit tool that they were using, it included items that ensured they were consistent with their regulatory requirements, but at the same time, they also embedded critical components that spoke to what does good person-centered recovery planning documentation look like from a person-centered and a recovery perspective. So it was sending the message that it was an equal and important part of quality, and embedded it right within that tool. And then similarly, before I turn it back to Dan, on the next slide, what he'll show you is a very nice example of something that came out of collaborative work in the State Office of Mental Health and the Transformation Center in the state of Massachusetts, where really important, you can't just be looking at quality and measuring quality in the documentation, because plans can look great on paper, and people can cross the T's and dot the I's, and that is not a guarantee that the process and the partnership was person-centered. So it's really important to also be observing, planning meetings, planning conversations, and to develop tools that have indicators of good person-centered process. So again, just trying to use this as an example to get you thinking about ways to reinforce this quality field.
Thanks, Jen.
Yeah, sure.
Okay. So one of the points is training is necessary but not sufficient. Again, you need ways to build in and reinforce the practice on a daily basis. Okay, I'm going to keep going here. Okay, and again, it's practice, 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 and more practice. There is methodologies to this, again, in working with Janis and the folks from P.C.R.P through the years. There's different ways to do this, through introductory sessions, followed by with more in-depth work with supervisors, where we actually create plans together, process them together, experiential in-service training with staff. I'll share something, that hasn't even happened yet. Janis and I were just talking about it yesterday. So we're in the process of implementing a new electronic health record in Rhode Island, and have worked with Janis to basically, design the new record based on person-centered principles. So with any luck, we are nearing our go live, and people will be faced with converting from an old, more traditional problem-based plan to a person-centered plan as we make the conversion to the new electronic health record. So we talked about in the training of actually doing that with folks, that, within the template of the new record. We're actually going to load in examples and then actually work through plans with the participants, and we'll be focusing on the supervisors where they can actually make the change and see what it's going to feel like, and see where, for example, they don't have the information they do need to do a person-centered plan. Because in the old system, they didn't necessarily ask the questions, or the assessment didn't draw on the questions you needed to really be able to do a proper plan. Okay.
Ingrid, Dan, just interject for 1 second. Ingrid, I think Dan wants to see not a new poll, but can we pull up the feedback from the first poll?
Yeah, the results.
And then also, Dan, just a quick time management thing. About 10 more minutes, if that's okay, so we can leave about 10 minutes for questions. Great.
Yep. So I've just quickly to look at this. It looks like clearly the number one concern, or that folks are going to be too impaired or uninterested to partner in what PCRP requires. Let me just tell you a quick story on that one. When we started this in Connecticut, one version of this was, oh, we're just going to get bizarre goals. If you let people set their own goals, everybody's going to want to be an astronaut, or we're just going to have crazy, bizarre goals. So we were in an electronic format, and a few months in, we actually said, okay, let's pull the data on the goals and see what we're getting. And it was a very powerful tool when we presented it back to the staff, which frankly, it looked like your or my life goals. What we saw the most was, I want a job. I want some version of connecting or reconnecting to somebody that's important to me in my life. There were a number about some version of symptom reduction, but it was, I just want to feel less distressed from the these things that are besetting me. And it was a powerful tool to folks to actually see what goals people were raising, and that in fact reasonable goals could be set. Let me give you another example. We also did this one in inpatient unit where you know, not surprisingly, so this was a locked unit, long-term unit in a state-operated facility. The number one goal that people brought forth is, get me out of here, okay? And if you think about it from a person-centered perspective, that was a very organizing and sort of powerful motivation that was not at all unreasonable to folks. So even for people who are sort of at the most impaired, our experience was you found some point of connection, and that people generally know what's important to them, even in their most impaired states. And that if you use that as a starting point, it can really drive a process that a person is much more going to buy into. Okay. Let me, for the sake of time, let me move on. Ingrid, we could probably drop the poll back out. Thank you. Okay, so I have talked repeatedly about this core structure. So there's some ways to do this, and probably the most powerful is building your documentation in a way that reflects the values you're trying to use. And I'm going to talk a little more about that in a minute, and much more in our next presentation. I have found supervision to probably be the key juncture where you build skills and where you build capacity amongst your line staff that are trying to do this. So we mentioned it briefly, but there are ways to build tools into the supervision that actually focuses people on this work. there's ways to carve time out in regular team meetings. Again, if you think about, we operate ACT teams here. If you think about a morning meeting, there's probably 30 things that need to be focused on during that meeting. It takes the conscious effort to carve out a piece. I've found actually if you do that and start focusing on sort of positive sort of goal attainment items in with people they're working with, it tends actually to change the tone of the meeting, whereas meetings can get so focused on the most problematic issues. It's a very good reminder to people that people are actually getting better and can get better. How you build things into job descriptions, performance reviews, if you include core competencies, and the use of data is very powerful. Just, again, very quickly, we'll talk a lot more about the forms, but we've come a long way, but we're not there yet. So 2 weeks ago, we had our Joint Commission visit here in Newport. We had, they said the magic words, you can choose your own charts, which was great. We chose a case. We're actually working with a new tool, which is an outcome management tool, which actually allows a person live before every session to have direct input into the session through tablets or their smartphones. It's very cool. So we had our clinician present it and blew the surveyor away. He thought, wow, this is an incredible, inclusive tool. The person's involved. Can you show me this treatment plan? And we pulled up the treatment plan, and you could not find a piece of that work in it. Okay? So there is still this disconnect between the work and the documentation of the work. And we'll talk more about that, of how you try to bring those together and get over those barriers. I noticed a lot of you in the poll did put sort of the time factors in there, which is one that I hear a lot, but there are ways to address that. Okay. I've mentioned a couple times about measurement. Again, and I'm not going to go into the detail here, but the more you bring data to the forefront and make it important, again, the few examples I used about, you can use it for a lot of purposes. Just want to get to this, okay? To evaluate your work, you can use it in supervision. One of the tools we had in one of our tools was we had in our record the ability to, so I'm the supervisor and I'm working with a clinician. I was able to pull all their goals for all their clients in one report and kind of look at, if there were sort of patterns in how that person was writing their plans. And there's some great stuff, but you would find clinicians, and lo and behold, every client seemed to have the same goal. So it was an important use of the data, and it was great to have that data as a teaching tool to help sort of inform what goes on there. Okay. All right. I think I am about, one more thing. Okay. I'm going to go to, and I'm just going to mention it quickly because Janis did as well. The other leg in this recipe, or part of this recipe, is an activated, empowered clientele. When we started this, we did a poll about, what do you think about your treatment plan? And the most frequent answer was, what's a treatment plan? And the second most was, that thing I sign every three months. And over time, and it took quite a bit of time and quite a bit of education, and a lot of work with our peers, people tended to get more empowered, and once they did not want to go back. Okay, so, and again, I don't have time to go into it, but we did a lot of work with our peers about sort of prepping people, helping them formulate what they wanted and how to articulate and advocate for that. And once you start that process, people do not want to go back to being told what to do. And it becomes a powerful force in trying to keep these things moving forward. Okay, so let me stop there. I'm going to turn it back over to Janis and open it up for any questions here.
That's great. Thank you, Dan. I've been keeping an eye on the chat box, and I'm going to throw out there a couple of really good questions that got asked by the group. We had Deb asking about, how do you handle maybe a community mental health center that appears to be resisting the implementation of person-centered recovery planning? And I would say a couple of things. First of all, you need to find out what is the source of the resistance, right? So for example, even that brief poll that we led you through around top 10 concerns, Dan did something very strategically years ago in Connecticut where he collected anonymous feedback from the staff and other stakeholders about what are you most concerned about in the implementation. And once you have that data, it's really critical because if someone is concerned that doing their documentation in this way means they're going to compromise their medical necessity or they're not going to get MCO authorization, then that's one kind of training and intervention. Another source of resistance may be that people are concerned about opening sort of the risk and safety issue around quote-unquote choices that people make. That's a different kind of support in TA. And lastly, I would say sometimes what you hear, especially from practitioners, sometimes what's really in their way can be policy and procedures that are set at a higher level beyond their control, which sometimes includes state authorities. It can include the interpretation of regulations, and that really begs some real good collaboration across different levels of the system. So I would just really say it's important to wrap your head around where they might be stuck, because that then informs how you intervene and help them move past that. So that was one question. I don't know, Dan, if you want to add anything on that, or if I should take another one.
No, again, I think your point that sort of identifying the source of the resistance and being able to sort of hone in on that. And again, as I mentioned, sometimes data can be really powerful in, I call it debunking myths or, helping people to get used to it. Again, we used a number of approaches. One of the things that was the most powerful thing we did in one of our training, we actually had one of our clinicians working with an actual person they were working with before in front of a room of people, and they actually went through the process together, and it was amazing for people to see that it could be done. So again, there's a number of techniques you can use sort of depending on what the source of the resistance is.
Yeah, definitely. Let me tackle a question that I apologize if I get this wrong. Tambria asked, kind of talking about the pressure in the documentation where, supervisors are really asking for less documentation, not more, and this makes things very difficult. Again, we did a preview of the documentation and how you can really continue to honor the person but meet your documentation requirements. That is going to be a heavy focus of our webinar on the 19th. But here's what I will tell you just as a preview to that. Oftentimes when plans are written from a traditional problem-oriented way, what sometimes happens is, especially when people enter into a system in public behavioral health, by the time they're receiving services, especially because there might be a whole bunch of other psychosocial stressors that go along with the experience of poverty, they may have a long list of quote-unquote problems coming out of that assessment. So when we write traditional problem-based plans, sometimes we end up with a list of 10 problems. We got a goal for every problem. Every goal has to have an objective. And then you got to match a set of services. And then lo and behold, you end up with a 15, 20-plus page plan that is impossible to write as a practitioner, but more importantly, that is not a meaningful roadmap to recovery for the person receiving services. So what I will tell you is that we are actually, believe it or not, big fans of the concept of less is more when it comes to recovery plan documentation. And there are methods to really prioritize what you're including, what you address now, what you might address later, and what may not be of interest. So there's a prioritization process in that, and there's also ways to integrate content into a meaningful, more streamlined way, rather than carving it up into 10 different pages of problem-driven treatment plans. So we're very sensitive to the tension that you're raising, and we'll give you some more tips on that on the 19th. I didn't see other questions in the chat box in my scrolling of them, but one thing I do want to point out, and participants are muted, but in your chat box, Bevan Croft, who has a leadership role in the National Center for the Advancement of Person-Centered Practices and Systems. I apologize if I didn't get the acronym right. I'm still learning it myself. It's a mouthful. But Bevan put in the website address to the NCAPS initiative, which is something that's really exciting, that's looking at person-centered thinking and practice across different systems of care, serving people with different types of disabilities across aging, head injury, might be developmental or physical disabilities, behavioral health. And NCAPS is shaping up to be a really tremendous resource with a very nice resource library. And as that is built over time, it should be a good resource for this audience. So I just wanted to point out that that website is in the chat box, and to thank Bevan for including that. And any other questions out there? We're just going to see if folks are. I think I hit on most of them in scrolling through. Let me make one plug for something around Dan's point that training is necessary but not sufficient. As you all think about ways to support your implementation, there is, as Dan said, a very strong tendency for people to just want to blanket their state or their system with these big traveling road shows of training, if you will. The folks I worked with in Kentucky for, a number of years, they would call it sort of the spray and pray method, right? Like you get all these, webinars out there and training, sort of never to go back to the people who are then trying to implement these practices. And it's just really important to recognize that you don't get traction with that kind of an intervention. As Dan and I have been saying, hopefully you see that there's a lot of follow-up and alignment with policy, procedures, supervisory methods, quality management tools, et cetera, to really help people who have good intentions do their work in this way. So I just wanted to emphasize that, because I think it's a really important point. There's another website, just check it out. Marguerite, thanks for adding that in the bottom left-hand corner there, to check out some of the work of the High Hopes Clubhouse, doing some work in this area. I am conscious of the fact that we are rapidly approaching 2:30, so I'd just like to, first of all, thank you all for your participation, your comments in the chat box, the poll with us. We hope that many of you will choose to join us again on the 19th, where we will take that deeper dive, both into looking at, again, how you sort of co-create the actual recovery plan documentation in a way with a person that still satisfies the very sort of complicated mix of requirements that you're subject to. And Dan is going to help us tackle common questions that come up for those of you that are in the process of designing electronic health records, because that's an area that's of great interest in the field right now, and we thought it would be helpful to cover. You have up on the screen right now that in addition to our webinar on the 19th, there's a bunch of other exciting offerings coming up through MHTTC. So please check out the website and feel free to register for any of those. And last reminder, I think technically, for those of you that are interested in the CEUs, please do remember you have to participate in both webinars. After the second webinar, you would get a link for the knowledge check and the evaluation, at which point you'll be eligible to receive your certificate. So with that, Dan, Ingrid, anything that I left out that you can think of?
No, just wanted to thank everyone again for, spending the time with us, and hopefully you'll join us again in 2 weeks.
Thank you, everyone.
Thanks, everyone. Enjoy the rest of your day, and hopefully we'll chat with you in a few weeks. Bye-bye.
Bye.